Hi, everyone. I'm just going to wait a minute here as everybody's coming in from the waiting room. Thank you for being here. If you're just joining, I'm just waiting a minute as we have people still joining from the waiting room. Thank you. Okay, so let's get started. Welcome, everyone. Thank you for joining us for today's Caring for the Caregiver webinar, presented by the Executive Office of Aging and Independence in collaboration with the Mass Tech Collaborative. Today's topic is When the Brain's Warning System Fails, Understanding Dementia's Hidden Challenge, Strategies for Communication, Safety, and Caregiver Well-Being. I'm Liz Gallagher, Strategy and Analytics Manager at the Executive Office of Aging and Independence, and I'm thrilled to welcome you to this important discussion. Before we get started, I wanted to set the stage for what we'll be talking about today. So imagine a computer with antivirus software that stopped working. Normally, the antivirus would scan for problems, detect threats, and send alerts when something's wrong. But when that system fails, viruses can spread silently and no warnings appear. That's what happens in the brain with anosognosia, a neurological condition common in dementia. When the brain's self-monitoring system is damaged, a person doesn't realize they're experiencing cognitive decline, no matter how obvious the symptoms may seem to loved ones. This lack of awareness is not stubbornness or denial, but a direct result of brain changes beyond their control. Understanding this condition is critical because it directly impacts important care decisions such as medications, driving, and future care planning. When families recognize their loved one isn't intentionally resisting help, they can approach these situations with greater compassion and make decisions that prioritize safety and dignity. I'm very pleased to welcome our speaker today, Chris Wight, Senior Clinical Social Worker at Mass General Hospital Outpatient Neurology. Chris holds a master's degree in social work and works in both the Memory Disorders Unit and the Movement Disorders Clinic, where he supports individuals and families living with dementia. Today, he'll share real-world examples and practical strategies that can help caregivers navigate the challenges of dementia with greater confidence, compassion, and care. Before we begin, a quick note for those attending live. Please feel free to post your questions in either the Q&A box or the chat. You can also submit your questions anonymously if you'd like. Please do not include any personal or identifying information in your questions, and there will be dedicated time at the end of the session to address questions. Live transcription is enabled for this webinar, and you can access the live captions by clicking on the CC or live transcript button in your Zoom toolbar. Thank you again for being here today. And now I'd like to turn it over to Chris. You can take it away. Thank you.
All right. Thank you, Liz, so much for the wonderful introduction. Very happy to be here, and I'm looking forward to talking about this particular topic. And so with that being said, just to first briefly just review again my master's in social work from Salem State University. I've been with Mass General since 2019, originally working in the Division of Palliative Care as part of the Dementia Care Collaborative. I then moved over to work full-time, integrated within the Department of Outpatient Neurology here at Mass General, where I've been ever since. I will say that, for our discussion today, or what I'll be presenting, I will be going over some medical information, and there will be some medical terminology. I want to emphasize that I am not a doctor per se. This is just based solely on my experience in working with patients and families living with dementia spectrum diseases, And so, there will be topics which I'll be going over, but not in too much detail, just to the best degree that I'm able to, explain them competently. So, but with that being said, I think, and Liz gave a wonderful introduction in terms of what this topic will be about. But before I go into that, I do want to set the stage, and I think it's important really just for everybody here, for all of us to have a shared understanding of what it is that we're talking about when we say the word dementia. Okay. It's been my experience that sometimes this is a term that can kind of be thrown around, and sort of like kind of incorporates, or, the assumption is that, everybody deals with dementia, as we get older. And this is absolutely not the case. So when we say dementia, we are talking inherently about a medical condition, okay? And that from the outside, the outward signs of somebody living with dementia are, all the symptoms that you can see on there on the right-hand side. These symptoms that, memory loss, challenges in planning and problem solving, confusion, trouble with visual spatial perception, difficulties with expressive communication, misplacing things, poor judgment, social, emotional withdrawal, and changes in mood and personality. These are just some of the wide range of symptoms that can occur with something like dementia. Okay. Now, dementia has many, different explanations or different causes. What you see here on the screen is, these are the core underlying etiologies for dementia spectrum diseases. Dementia is, what we would call an umbrella term, and that dementia can be caused by a number of different conditions, such as Alzheimer's disease, vascular disease or vascular dementia, Lewy body disease, Lewy body dementia, and frontotemporal dementia, frontotemporal disorders. Okay, these are just some. This is not the entire list. There are actually many others that can cause very similar symptoms. The key thing to understand here is that these are diseases, meaning that these are not naturally occurring, for those, getting older, or as we move on in life. These are actually things that are outside of our ability to fully control. These are progressive diseases, meaning that unfortunately, while, my hope would be that we have, better treatments and, fingers crossed, a cure within our lifetimes, at the current moment of us talking, we don't have that. So these are progressive illnesses, and that once they are here, they will get worse over time. Okay. But that's not to say that there aren't also things that, can mimic memory changes, cognitive changes that we see in dementia, but might also have reversible causes. So this list you see here on the left-hand side are things that, not only can mimic dementia, but if we're also talking about them co-occurring with dementia, they can also cause a lot of problems as well. Particularly things like infection, UTIs are a pretty common culprit in that realm as well. Okay. So whenever we're, wondering or worried about, changes that we might be seeing with our loved ones or people that we're caring for, I think it's always important to be in communication with your doctor, with their doctor, with their medical team, because one of the first things that we want to try to do whenever we're seeing changes in any cognitive domain is rule out any of these reversible causes, because they can be cleared up, and a lot of times they can lead to, better outcomes, and, we can resolve the issue. But just to say that there are a lot of things that can account for changes that we're seeing with cognition and memory, right? So just to emphasize the point of what we're talking about with dementia, because it's something that I think for a lot of people can kind of go understated in terms of, the diagnosis itself, what it's actually doing physically in the brain. Okay. So dementia is part of a family of diseases that are classified as neurodegenerative. Okay, meaning that what's happening in the brain is that these diseases are causing brain cells to essentially die. Okay, this can be a slow process over time. It can, and, might not be, immediately evident, even on, in early stages when imaging is done. But as you can see here on the right, over a long enough course of time, we can actually see that the brain physically changes. It actually shrinks because there's not enough basically brain cells to sort of, fill out the volume. Okay. And so this damage is something that is very real. Okay. And much like any other disease that we might have throughout our body, this damage in the brain and really leads to brain cell death over time. Um, and what I'll go into next is why this damage is so important, because the brain is, a very, very complex organ, and it's made up of a lot of subdivisions which play very important roles. Okay. So just to review, this is a very brief overview of the brain. Okay. We can see here that it's divided into several key areas. We have the frontal lobe, the temporal lobe, parietal lobe, and the occipital lobe with the cerebellum and brainstem. Okay. I'm not going to go over every single part of the brain today because that I think is just a topic in and of itself. But what I want to focus on today are two areas of brain which are critical for today's topic. Okay. And that is the temporal lobe, which is this area that you can see outlined in green. Okay. And this part of the brain is really key in terms of, regulating and moderating emotions, but it's also really the key area of the brain when it comes to memory. All right. Short-term and long-term memory predominantly. Okay. It's important to know that short-term memory is usually one of the things that is most commonly associated with dementia, the difficulty in retaining and recalling things that have happened within our distant, present awareness. Okay. And long-term memory, which, relates more to like our early childhood memories or things that happened in a far distant past, like months or years ago. Okay. Short-term memory is generally speaking limited to around a 24-hour time frame. Okay. So that's the temporal lobe. And then the other super important part of the brain, which I think plays an even more leading role in our topic today, is the frontal lobe, or the prefrontal cortex, as it's also called. Okay. As you can see here, the frontal lobe is responsible for a whole lot of things. Okay. And it's the seat of what we call executive functions. Okay, so these executive functions, it's another term that basically pertains to everything, a lot of the skills and cognitive knowledge, and a lot of the regulation aspects of our brain in terms of moderating our impulse control, our behavior. Okay. So a lot of the things that we grow up and that we ultimately learn through the act of living, what we're taught by our friends, by our family, this is where those skills are stored. Okay. And right down there at the bottom, you can see in big bold letters that this is also the seat of judgment, insight, and awareness. Okay. Hence why this is so important for our topic today. Okay. This brings us to the $1 million term today, anosognosia. Okay. Anosognosia is a term that basically pertains to the difficulty or impairment of the ability to be aware that changes are happening to us. All right. In my practice, in the work that I do here at the hospital working with families, what I have come to find is that this term, this syndrome, this complication really sits at the core of why dementia is so difficult to manage for both patients and with families, because it relates to, the ability to understand and to be aware that we're having difficulties or that there are changes is really key in terms of having any conversation when it comes to treatment, when it comes to making changes, when it comes to making decisions. Okay. I mentioned before that the temporal lobe earlier is responsible for memory, but also just another key structure of the brain to be aware of in this process is the hippocampus. Okay. So this is the part of the brain, the specific structure that really regulates the retention or the retaining of short-term memory and the processing of short-term memory into long-term memory. The hippocampus is one of the key areas responsible for that, and it's very deeply connected with the frontal lobe of the brain. So it's like almost like a partnership in terms of us. So basically, our brain takes a snapshot of its status. Okay. And, but if we're unable to retain or recall that snapshot, that sort of internal picture, that explains why a lot of times we have this difficulty with insight. Okay. It is not exclusive to dementia, anosognosia. We actually see it in other serious medical conditions, as you can see there on the right. The commonality between them is that with stroke, with schizophrenia, with severe bipolar, and also with traumatic brain injury, there's either a severe disruption in how the brain is communicating with each other, meaning from the frontal lobe to the temporal lobe and vice versa, but also some of those conditions there on the right result in damage to the brain that is oftentimes irreversible. Okay. So in some way, shape, or form, there is some form of disruption in the communication that the brain is, having with itself. Okay. Short-term memory loss compounds anosognosia. Okay. There's a term that I use in my work called moments of clarity, where there's a phenomena with dementia where a person might have limited awareness for most of the time that they're dealing with the disease, but there might be days or there might be moments where a person almost it's almost described as somebody's emerging from a fog, where they have better awareness, they might have better recognition, something to the effect of, oh my God, I actually understand now. I have I'm more aware now than I was, before. But the problem is that, if a person living with dementia is unable to remember that moment of clarity, you know, it often still results in the same lack of awareness in all other cases. Because again, if you can't remember that moment of awareness, a lot of times it's almost to the person like it never happened. All right. And this leads me back to the analogy that was brought up in the beginning, where anosognosia, is essentially like, the brain's self-detection and self-monitoring system, its antivirus software, stopping working. Liz did a great job in terms of giving that overview. I liken, the brain's ability as like, a fundamental skill is being able to detect when things are wrong. Antivirus software, that's part of its primary role, is that when something's wrong with the system, internally, it sends you that pop-up, it sends you that, message saying, hey, we've detected X, Y, and Z, and this is what we're going to do about it, right? But again, what happens when that software, that skill, what happens when that stops working, right? There are no messages being sent to you. There's nothing being brought to your attention. Okay. And so things can continue to get worse, but the person might not, but the person, operating the computer, because the software's not doing its job, continues to just operate as normal. There's nothing wrong because nothing is being brought to their attention. They are not able. But even again, going back to the memory aspect, even if a message were to maybe slip through every now and then, if the person's not able to remember that that happened, the next day, might occur, as if that event never happened in the first place. And so this is why it's so tricky, is because awareness might be impaired, but even those moments where, a person might have better awareness, better insight, it's not a guarantee that that will hold, moving forward, because, it requires them to remember that. It requires them to be able to recall that moment of clarity. And this brings me to, another aspect, because what I see, like when I get referred patients and families for the first time, and I'm sitting down, um, a lot of times with family members or primary caregivers, what tips me off that, this might be something to consider is, when family members are telling me, one of the primary frustrations or concerns that they have, in some way, shape, or form, saying to me, um, it's, my loved one is in denial. Okay. But if we're talking with patients, there are also things that sort of key us in, as to whether this is something that we need to be worried about. And what you see here, in this slide is basically a brief overview and the distinction between what we're talking about, anosognosia, and what we might consider more sort of traditional denial. Okay. Um, it's very subtle, but at the end of the day, the best way that I've learned to explain it is that for a person to be in denial, the requirement there is that, awareness is intact, awareness is there, the information that would lead to that, conclusion that there's something wrong. The person has that, but they are choosing to disregard it. They're choosing to suppress it because, you know, that awareness is causing them distress. Okay. With anosognosia, right? Very similar, but the thing here is that that awareness, that information is not present. The person is genuinely unaware that there's a problem. Now, this is one point I just want to make very quickly before we go into, an example that I want to give folks here. But, there's a lot of nuance to anosognosia, and, it's a complex topic in and of itself. Okay. you know, Anosognosia is not guaranteed with every case of dementia. I want to make that very, very clear. I can tell you that I work with plenty of patients where insight, is pretty well preserved even up until the end. Okay. It's also not an all or nothing symptom, meaning that it's not a situation where you either have insight or you don't. You might have differing levels of insight. For example, a patient might know that, I have memory problems, um, but they may not have the full insight to know that, if there's something that I'm having difficulty with doing, it's because I have dementia or it's because I have this illness, right? So there might be some insight, but not to its fullest extent. Okay. And also, really critical here, just because a person may not have insight or awareness does not mean that they've lost capacity to make decisions. Okay. This is something that often comes up in conversation where, the question that gets asked me is like, well, if what you're telling me is my loved one doesn't, understand or have insight as to what's going on, like, can they make decisions? And the answer to that is no, not necessarily. There's so much there's a conversation always to be had. You know, I think that in many cases, capacity to make decisions is something that can change over time depending on the circumstances, usually relating to a patient's, to a person's safety, but it is not a guarantee and it is not something that we take lightly. Okay. This is always a conversation that we have here with patients, with families, with their medical team. Um, and there's a lot to consider and can be a really difficult conversation at times. Okay. But that leads me well into communication and why it's so key and how it ties in here. So in my work, when I'm speaking with families and we're talking about how to manage the challenges relating to anosognosia, because it can be really challenging. Think about it from this perspective. We as family members, as caregivers, often see all the symptoms, all the changes that are happening with this disease. The person themselves might not think that anything's wrong, right? So it begs the question, so if we're trying to help or institute changes to keep somebody safe or to support somebody living with this dementia, how do you help someone that thinks that they don't have a problem, right? Communication is key and really the core pillar here in terms of how we go about shifting our understanding in a way that we have more opportunities to really support folks living with this condition. Okay. And it's so critical to all aspects of care and quality of life. I cannot understate that enough because the conflict that often and the tension that often arises from this lack of understanding, from this lack of insight, oftentimes, and again, going from my experience, leads to a lot of frustration, resentment, and anger. Okay. It can be difficult, to be patient with somebody, that seemingly is in denial, right? If we think that a person's in denial or just being stubborn, it can be really hard to be patient or to be compassionate towards them because we feel that like, well, they're just in denial. Like, why should I care more than they do? Right? There are these vicious cycles that come about as a result of this, and it really can be difficult to break out of once it kind of gets into this feedback loop, right? So these common themes that I hear all the time from families are, as you can read there on the right-hand side, um, and it can be so difficult to deal with, and it's, the question that gets asked me is like, well, what do I do? You know, I don't understand. We've had this conversation 1,000 times. It's a good one. I keep trying to convince my loved one to accept help. Why don't they understand? They don't want to admit. All of these things, again, are key indicators that this is something that I think is really important to consider. Okay. So this is why anosognosia is so challenging because as caregivers, as family members, we try to do things to support, those living with this disease, but oftentimes we get pushed back or we run into barriers and the question becomes, well, what do I do? It's important to know and for us to understand first and foremost is that this is part of the disease. It is something that is not fully within their ability to control, right? And so if we understand that this is not a willful process, that this is not personal, in my view, it gives us really an opportunity to shift our understanding, shift our assumptions, okay? We can respond in ways that, we can avoid what I like to call or what are called catastrophic reactions. Think about catastrophic reactions as being your arguments, your yelling, any sort of conflict or, emotional escalation that comes as a result of two people having a disagreement or two or more people trying to do things and meeting resistance. Okay. Especially when it comes to making sure people are safe. Communication needs to be focused on meeting the person where they are at. Because again, dementia is something that is not willful, is not within their ability to control. It is a physical disease. And as we, saw before, it is actually making physical changes to the brain. It is not their fault. So I wanted to give, in the time that I have, and wanting to leave plenty of time for some Q&A, to kind of maybe give, I think, a good sort of encapsulating example of how this sort of plays out in practice. Okay, so I would like you all to meet Mr. Dave and Dave's wife, Linda. Okay, so as I've written here, Dave is a 76-year-old male, has been living with Alzheimer's for a couple of years, and his wife, Linda, is his primary caregiver, care partner. Okay. So I get referred Dave and Linda, and over the course of time, there arises a scenario where Dave starts to have some worsening confusion, particularly at night. For those of you here, you might have heard of the term sundowning. This is something that can happen as a disease progresses with something like sundowning, where cognition, orientation gets more severe at night for a variety of reasons. But what happens with Dave is that he starts to struggle with recognizing his immediate surroundings. Okay. He starts to feel anxious. He starts to, he approaches Linda and says, I want to go home. Mind you, they've lived in their home for many, many decades. Um, it has been a long time since Dave has lived anywhere else other than where they currently are. Okay. So understandably, the first couple times this happens, Linda, I think, responds pretty understandably in a way where she attempts to reason with Dave. She says to him, Dave, what are you talking about? You are home. Like what are you talking about? And she endeavors to try to convince Dave during these episodes that no, he is in fact home. and he shouldn't leave. Okay. The problem with this is that Dave, in those moments, is dealing with something, again, that's beyond his ability to control. And what I tend to interpret this as is that, again, Dave is disoriented. He's not able to recognize his surroundings. This is something that's causing anxiety to build. So it causes anxiety to build and it makes his agitation worse. Okay. Over the course of several weeks, this is a source of really of a lot of contention, a lot of tension between Dave and Linda. Okay. Linda continually tries to reason with Dave. She tries to explain to him that this is a result of his disease. All right. He's been diagnosed. He's been officially diagnosed for many years. And initially, Dave did have insight. He was able to recognize and, be able to understand, in conversation that he had dementia, that he had struggles. But now we were seeing a different, this was something different. All right. And so Dave in these moments was suffering from an exacerbated, symptom of dementia. And in these moments, wasn't able to exercise the same level of cognitive strengths he used to in the past. His level of insight was lower in these moments. Okay. So what ended up happening was that, these arguments, these episodes continued to the point where there came one night where, in the middle of a heated argument, Dave proceeds to say, "You know what? I'm just going home." And he starts to head out the front door. Okay. Linda, again, very understandably, and despite all attempts to try to, wrestle with, not physically wrestle, but verbally wrestle and try to convince him, she becomes very upset. She tries to prevent him from leaving. She gets between him and the door, saying, "I don't want you to leave." And this, because Dave is in such an escalated emotional state, because they've been arguing back and forth, and this has been going on for weeks, Dave proceeds to push Linda to the ground and walks out the front door. Linda, still upset, still, escalated herself. She tries to follow him. She follows him. She shadows him down the street. Again, trying whatever she can do to try to bring him back home. Dave's at a point where he's not listening. His emotional state is to the point where reasoning is not necessarily something that it's possible at that moment. Finally, feeling that she has no other option, Linda calls 911. Police are involved. They are ultimately able to bring David back home safely. So David gets home safely, but in my talking with Linda again recounting this tale and asking me, what could I have done? What could I do in that moment? Right? And so we bring back into the forefront the concept of anosognosia, that fundamentally, this is a moment where Dave is not able to understand or have insight as to why he feels the way he feels. Understanding that, him wanting to go home is more of a response to him feeling anxious and unsure and out of sorts. Imagine if you were to feel like, imagine if you would for a moment that you are all of a sudden teleported to somewhere that you had no idea, you couldn't get your bearings, right? And it happens just out of nowhere. You're blindsided. It would be very understandable that if you were all of a sudden in an environment where you didn't recognize where you were, you didn't know where you, like what time it was, what day it was, what month it was, etc. I think a very core impulse that many people might often feel in that situation is, I want to go home. I want to go somewhere that I feel safe. Coupled with the inability or this, lowered level of insight means that by Linda trying to convince him that he was already home, what she's essentially doing in that moment is challenging his version of reality. That example I gave you, or I gave it all of you, in terms of, feeling that you're in some place that you don't recognize, you want to go home, you want to go somewhere where you feel safe. Now I want you to imagine that you're with somebody that, you trust, somebody that you love and trust and that you're looking for support. And the response that you get from that person when you say, I want to go home, I don't feel safe, I want to, I want to get rid of these feelings. And the response you get is something to the effect of, what are you talking about? You're already home, right? Your concerns are being challenged. What you perceive to be reality in that moment, you're being told now that that's not correct, that you are in fact wrong. For patients with dementia, this is a core reason why the, correction, that first point up there, often results in an escalation of these types of scenarios. Because what you're saying to the person is that, no, you're wrong. What you're thinking is real is not. That can be disorienting in and of itself, at least in the experience that I've come across with so many families that go through scenarios and situations like this. And so in working with Linda, my focus becomes on, okay, so well, we can't perhaps reason with Dave. What do we do? Right? Do we just let him leave? And no, not necessarily. Our goal at the end of the day, the first and primary goal is to try to make sure that, our loved ones are safe. Leaving the home, or wandering as it's sometimes called, can be a really challenging symptom, and it can really lead to a lot of um, really notable safety concerns. So we want to try to support somebody, but again, it's so important now that we know that, in that moment, Dave doesn't have a lot of insight. Anosognosia is more prevalent here. You know, we want to focus more on first of all, gathering information. We want to have a better level of understanding in any given scenario as to what Dave's, or anybody like Dave's frame of mind. So asking questions is a really good way to not only gather that information, but it also gives us opportunity to sort of gently lead Dave down a different path to focus on something different. Okay. There's a mantra that I like families to focus on in these moments, and that mantra is reassure and redirect. With reassurance, our goal is to really make sure that we're conveying to a person that they are safe, they are loved, they are cared for, that whatever it is that they're worried about or that they want to do, it will be addressed or it will happen at some point. And then the redirection part comes into trying to gently sort of steer the conversation and steer that focus onto something else. The goal here being, and again, given the complexity of dementia, we're sort of trying to allow for the disease process to work its course. And so that, whatever was sort of prompting the initial elevation anxiety subsides. All right. And so that's what I do in practice. For Linda, it was all about understanding that Dave's inability to understand what was happening, that was the key. Because once she stopped trying to correct David, once she stopped trying to reason with him in those moments, it became easier for her. Her body language changed. Her whole approach changed so dramatically. She was able to talk with David and sit down with him. She brought in pictures and, photo albums, right? And they were able to have great conversations to the point where, the initial point where he would come to her is like, I want to go home. They would sit down, they would have a conversation, they might look through some books, and then all of a sudden, maybe an hour and a half later, David might say, what were we talking about before? And the whole thing had passed. And so the whole catastrophic escalation that was taking place over the course of weeks, to the point where, there was a physical altercation, just by making this simple change in terms of understanding what she was dealing with, made all the difference. And it gives her such a powerful tool to utilize, because this happened to be working in the time that I was working with this family. It's not to say that it would be the end all solution. There might be times when, despite all best efforts, Dave might not even be able to be redirected, but it at least gave Linda the chance to, meet Dave where he was at and allow for a constructive dialogue. And it allowed her to, you know, to meet him where he was at and give every opportunity to avoid the catastrophe that she had that one night. And this is why anosognosia, all this lack of understanding, this lack of awareness, and also this is just like a microcosm. This is a really I think a worst case scenario in a lot of times. But anosognosia can also rear its head in a lot of different areas of care as well, right? Managing finances, making decisions, all those things can come into play. And so it's something where we have to be cognizant of the fact that, this is not the person, this is a part of the disease. Okay. For those of you who are interested in learning more about this topic and a lot of the communication strategies and care management strategies, I would encourage you maybe to take a look at these two books that I have here up on screen. I will make it known I have no vested financial interest in these two sources here that you see before you. I have just found that they, in my view, do a pretty good job of going in detail the topic that I've gone over today. And I think it might be helpful for those that are learning to learn more about the complexities and challenges of caring for loved ones with dementia. So, um, but yeah, that's all that I have, and I'm happy to take questions and hope that this was helpful.
Thank you so much, Chris, for your informative presentation. We really appreciate you sharing your insights and experiences with us. And I especially loved, and I'm sure our guests will as well, the mantra that you mentioned, the reassure and redirect, and easy to remember as well. So we'll now shift to the Q&A portion of today's session. So while we welcome your questions, please note that we will be addressing general topics rather than highly specific or personal situations. If you do need individualized guidance, we encourage you to reach out to Mass Options or the Alzheimer's Association 24/7 helpline for direct support. So with that in mind, please feel free to post your questions in the Q&A box or the chat. And while we wait for questions to come in, I'm just going to take a moment to highlight those resources I mentioned. So if you're unfamiliar, Mass Options connects older adults, individuals with disabilities, and their caregivers with agencies and organizations that can best meet their needs in their local communities. And the Alzheimer's Association hotline is a free service offering support for those living with dementia, caregivers, families, and the public. And they'll connect you with trained staff who can provide information, local resources, crisis assistance, and emotional support. So I'll put those in the chat now, and I see we have some questions coming in. Here we go. Okay. So one of the questions we received for Chris was, what if you reassure and redirect and it causes more disagreement from the patient?
To be perfectly honest, I think that that's an interesting question just from the perspective of fundamentally, if we're telling a person, in essence, what they want to hear, what is there to disagree with? Now, not to say that it couldn't lead to perhaps, maybe more confusion, but again, I take this from very much on a case by case basis. I don't treat every if I'm working with families, I treat every case as an individual case, with all I like to explore all the nuances. There's something that I was taught early on in my career called chain analysis, which is a fancy
Mhm.
word for essentially breaking down like a situation like Dave and Linda's and really kind of going point by point. What was said, what was the reaction, what led to what, right? Because I think oftentimes in the heat of the moment, it's really hard to sort of like be acutely aware of sort of some of these dynamics at play. When I work with families, like I it's really important because like it's sort of like the debriefing process. Like, okay, let's see what worked, what didn't work, right? And again, what works for one person may not work for the next. And I've also, it's also something where I'm very, very happy to be proved wrong in a number of cases where if a family member does provide that correction, so to speak, and that solves the issue, fantastic. I'm more than happy to, in many cases, there being exceptions to the rule. Um, I think that for anybody that struggles with maybe situations like these where, even putting these, methods into practice still doesn't, fix the issue. I think it just goes to show that the complexity of this disease is such where, what works today may not work tomorrow. And I think it's always good to really be mindful of being flexible and adaptable in any given situation to the best degree that we can.
That's great. Thank you so much. And another question we received, oh, we have a couple people asking about whether they can watch the presentation later or whether it can be shared. And I have good news. We are recording this Zoom session and we do post the sessions to our YouTube channel. So in about a week or so, I would say we will have a YouTube link and I will make a note that we should send the link to all of you today so you can rewatch and review as well. Another question we received was, thank you for this knowledge, Chris, very helpful. Your case prompted me to wonder this. When the police de-escalated Dave, what do they do? Are police in general trained to do this?
Hmm. So that's an excellent question. And the short answer is that my hope is that yes, they are trained. They should be trained in a lot of these de-escalation techniques. However, there are a lot of nuance to this as well. For instance, how do police know upon arriving on a scene that a person in an agitated state suffers from dementia, right? Um, in the case of, like Dave and Linda, if there's an escalating risk of wandering or, something like, what I outlined in the community, a lot of times what I recommend for families is to go to their local police station and try to connect with either something along the lines of a community liaison or somebody that sort of is like a community integration specialist. So basically somebody that, can heed concerns that aren't like an emergency right then and there in that moment, right? What your goal there is to, inform your local law enforcement that, hey, my loved one living at X, Y, and Z address, is living with dementia. And we've been noticing that they've been struggling more with, wandering or agitation or something to that effect, right? Families might give the police their a picture, their information, and more importantly, the contact information as to who to call if, God forbid, something should happen and, police were, called to respond to something, anything that, relates to their safety and well-being. Okay. Um, de-escalation techniques that they're actually doing, again, I can't sit here and say that every police officer is trained in a very specific manner to this. But if I
Mhm.
could say some general themes that tend to emerge, number one, police being just genuinely in a position of authority, they tend to have an easier time with redirection because number one, oftentimes it's not considered personal. The example that I gave between Dave and Linda, mind you, is between a married couple. So there's all the emotional background, all the emotional history sort of deeply ingrained into these interactions. Okay.
Mhm.
And I see this play out a lot, even between other members of the family. There's a huge difference if I could say the same thing to a person and have it be interpreted completely different by another family member that has a different relationship with the patient, right? Um, and so, I think police, in my experience, if done in a thoughtful manner, tend to be pretty good about, making sure that the patients, doesn't hurt themselves or stays safe. And they're able, in a way, I think, in a lot of times, to provide that redirection without it being taken personal, right?
Mhm.
This is their job, right? As opposed to a family member is like, who is this family member to tell me what I can and can't do, right?
Yeah, definitely. That's really helpful. And another question, I think this is a very common question. So somebody asked, is it beneficial to use white lies to de-escalate a patient's concerns?
The short answer is yes. Because again, if we're going with the understanding that what we're dealing with is, a person's lack of awareness and insight being a symptom of this disease, I'm inclined to use those like little white lies, or what we call therapeutic fiblets, with the
Mhm.
goal of avoiding emotional escalation. Because as we outlined before, emotional escalation, if we can avoid that, we can potentially avoid, those catastrophic reactions. That's the goal, right?
Yep.
So yeah, I would absolutely, that's a core aspect of this. And again, and the response that I get from families is like, well, I don't want to lie to my loved one, right? I don't want to mislead them. And to that, I say, I absolutely understand, right?
Mhm.
I would ask the question though, um, if you were, in years past, if this were to happen prior to this disease, do you think that the outcome would be different, right? And I would also make the argument that, again, we're dealing with the disease. It is causing physical damage to the brain. This is not something that they're doing willfully. This is not them being in denial, right? I would argue that these behaviors, this presentation is the disease showing itself. And so if I say to the families, like, look, the goal is emotional, de-escalation. We want to keep the patient safe and we want to limit stress. We want to reduce stress as much as possible. And so I would make the argument that if we are using those therapeutic fiblets, and if you want to call it for what it is, if you're saying to yourself, yeah, I'm saying this, I'm not, this is not the truth, this is a lie, I would also make the argument that you're not lying to the person.
Mhm.
The person living with the disease did not ask for that. Nobody does. I would argue you're lying to the disease.
Yeah, that's so true. And another person noted that they're struggling with getting their family member to go to get neuropsych tests done in order to move towards a potential diagnosis. Have you ever run into a situation like that where the person's having a hard time even getting them to that first step of getting an evaluation, and how have you dealt with that?
All the time, and it's not, and it can be a complicated problem to solve. So I'm sorry to say I don't have a quick and easy answer for you on that. If I could make any sort of suggestion or recommendation in situations like these, I think a lot of times, working through a primary care provider can be really helpful.
Mhm.
Sometimes certain primary care providers can do preliminary cognitive testing. They can maybe do like a rudimentary MOCA test, or, which is the Montreal Cognitive Assessment. Um, but, I've also seen plenty of cases where, you know, families were able to get an evaluation scheduled. And the goal was not necessarily to try to convince their loved one to go, but more just focusing on getting the person to the appointment.
Yeah. Yeah.
It's very tricky. And again, I mentioned before, walking the tightrope of like patient autonomy and decision making, right? And so it's a really fine line, and there's a lot of gray area here when it comes to something like that. I think though, again, if I were to make any sort of hard recommendation, it is, we want to be mindful of like who has a good, what kind of relationship does your loved one have with their providers, with their primary care? Who could we bring into the conversation to try
Mm,
to address the issue?
yeah, that's really good advice. And then we also had somebody asking if anosognosia relates only to awareness around cognitive changes, or does it also relate to go into physical issues the person might be experiencing, like pain or physical symptoms due to another condition? So does it also affect how they process and understand pain and that sort of thing as well?
Pain, not necessarily, though I will say that from a physical perspective, it can in some ways tie very closely in with awareness of decline in physical function.
Mm-hmm.
An example I'll give is that with dementia, with like something like Alzheimer's disease, um, there can be fundamental changes to our ability to maintain our gait and our balance, right? Our ability to ambulate, with our core strength and safely, right? Um, Families often come to me and say, well, they fell a couple of times. They're really unsteady on their feet. I got them a cane or a walker and they just refuse to use it, right? When I explore a little bit more about the issue and they say, well, what happens when you try to, remind them to use the cane, right? Sometimes the response that they get is, I don't need a cane. I'm fine. I don't have any problems walking around. Meanwhile, they might have fallen for like the third time that day. So despite all evidence to the contrary, again, that snapshot of that fall doesn't stick around because they're not able to recall it, right? It's important to know and sort of to keep in mind that for us as humans, in my view, for us to be able to objectively sort of say, like, this is what happened to me, these are the changes that are occurring, it requires us to remember them.
Mm-hmm.
And if we don't, there is a pretty powerful justification for us as humans to say, well, I can't remember that, so to me it didn't happen.
Mm-hmm.
And so, yeah, from that perspective, I would say yes, the anosognosia can play a role in sort of this sort of like mitigation or, this sort of dismissing of physical symptoms. Now, pain is different, I would think, and I would, and I don't want to go too far because again, I'm not a doctor. Um, from my experience, I think it's just, pain plays a role, but that's more of a fundamental aspect of the brain in terms of like the signals that are being interpreted. But
Yeah.
I think for our conversation, it doesn't pertain as much.
Yeah. And I can tell based on everyone's comments, everybody has found this session super informative. We have somebody writing in about the question on having trouble getting a family member to go to the neuropsych testing. Someone noted spouses in their program have had success by offering to go together for an
Hmm.
evaluation to get a baseline for both. I thought that was really a great piece of advice. And then as well, I have another comment from Mary noting she's listening from the Department of Family and Medical Leave, and she wanted to remind everyone that if caregivers need to take time off to care for their loved one, they may be able to get partial income replacement and job protection through the paid family and medical leave program. And she's left her contact information in the chat as well as the website on mass.gov. So I just wanted to highlight that quickly. But unfortunately, this is all the time we have for questions today. But before I wrap up, I want to once again thank Chris for his valuable insights and thank all of you for your great attendance and participation today. We've had wonderful questions and engagement. As you exit the Zoom, please take a moment to complete our post-webinar survey. Your feedback is greatly appreciated and helps us improve future sessions. And I noted earlier, we will be reaching out with the recording of the Zoom as it will be posted on our YouTube channel, so you can go back and watch or share with others who might be interested. So thanks again, Chris, and I hope you all have a great rest of your day.
Thank you so much for having me.
Bye.